Good morning, everyone. Thank you for being here, and welcome to the 2025 CARE Summit. It's a pleasure to see the room filled with people who share a commitment to strengthening health across Europe, and I'd like to thank you all really for joining us this morning. I know it's cold out there. It's nice that those of you who made the trip from outside the city could be here, so it's a warm welcome from us and on behalf of the European Health Management Association. So what I think is that your presence really speaks to something simple but powerful. It's that health is not an afterthought within a thriving Europe, but indeed it's one of its central pillars. So we're meeting at an important moment. The European Union is shaping a strategic agenda, and the priorities that are being set today are going to define the direction of our democracies, our security, and our prosperity for years to come. Across the agenda, we see three central themes: free and democratic Europe, a strong and secure Europe, and a prosperous and competitive Europe. A shame, then, that health is scarcely mentioned in the strategy, because these themes, I think, and maybe most of you would agree, that these themes can't be fully realized without the existence of strong, resilient, and well-invested health systems. So that's why we're here today. In short, if Europe wants to achieve its ambitions, health needs to be recognized and treated as a strategic investment. Today's an opportunity for us as a community of health-minded professionals to raise our voices and make sure that that point is well heard. So over the next 2 days, as we discuss things like crisis preparedness, global health security, data, digital transformation, climate, and health system governance, I would encourage you all to use this summit as a platform to build bridges across sectors and to express with confidence that Europe's future success depends on a strong and strategic approach to health. The conversations we'll have here across our panels and breakout sessions, obviously with our opening session here this morning, they're going to lead us to a roadmap towards a stronger European health union. And as 2025 comes to a close in a few weeks, it's a great opportunity for us to shape the strategic choices that Europe will make in the coming years to benefit all citizens. So thank you again for being here. Thank you for the work you do every day. And thank you for contributing your expertise and, more importantly, your energy to the event this morning. So with that, it's my pleasure to officially open the CARE Summit, and we're going to get started with a video message from Commissioner Olivier Varhelyi. He's the European Commissioner for Health and Animal Welfare.
Ladies and gentlemen, thank you for the invitation to speak. The strong, innovative European Health Union can and should make our health systems more resilient for the future. We're standing on the brink of transformation in healthcare. If we can integrate health innovation across sectors and break down silos, the possibilities are endless. We have taken bold action at the EU level to make this happen. We are reforming the EU's pharmaceutical rules to cut red tape, simplify procedures, and bring in new tools that support innovation. It will make our system one of the most efficient in the world. It will also facilitate patients' access to medicines across our union. The Critical Medicines Act will complement this reform by reducing our dependencies around critical medicines and their ingredients. Its measures will make us more competitive because they will encourage investment and innovation in pharmaceuticals. We're working closely together with the European Parliament and the Council to swiftly conclude these two important files. We're also continuing to implement Europe's Beating Cancer Plan at speed. The initiatives coming over the next few years will build on its actions and its success so far. For instance, we want to foster a healthier workforce through prevention. We also want to take a more modern approach to cancer, making use of new technologies, research and innovation. The EU Health Technology Assessment Regulation will help to make this happen. This new framework will provide timely, high-quality, evidence-based evaluations of new health technologies, starting with cancer medicines and gene therapies. It will guide member states in their decisions, making to meet patients' needs. This December, we will take another big step forward with our health package. First, the Biotech Act will help scientists bring their products from the lab to the factory and onto the market where they can change patients' lives. Next, the cardiovascular plan will address the huge burden of cardiovascular diseases, the single largest cause of death in Europe. Finally, we will propose a simplification of our rules on medical devices to make it easier for safe, effective devices to reach patients. We're not working from scratch. Much of the transformation in healthcare will happen through data and AI. But one major barrier is access to quality data. The European health data space is breaking this barrier, and it is designed to empower people. It gives every one of us access to health data for what we call primary use. It also allows researchers, developers, and regulators to access high-quality data sets for secondary use. In this mandate, we're focused on putting it into action and achieving real impact. Ladies and gentlemen, we are setting the stage for a transformation in healthcare. In everything we do, patients are front and center. Thank you for your support. I wish you a very good summit.
Great. So thank you again to Commissioner Vahey for providing a great way to set the table for us this morning. And now it's my pleasure to introduce our speakers for the opening plenary session this morning. I'll invite Dr. Ewout van Ginneken to the stage, Director of the European Observatory on Health Systems and Policies, Ms. Charlotte Marchandise, Executive Director of the European Public Health Association, Michele Calabro, the Director of EUREGA, the European Regional and Local Health Authorities, and Ms. Federica Marghere, the Director of the European Health Management Association. Thank you all for being here, and I'm going to cross this awkward gap to... So I will get us started, I think, with you, Federica, because the Commissioner set the stage on what's happening with health at the European level. There's a lot of important initiatives that are taking place. But, of course, we're here today to talk about some of those and then maybe expand on those ideas. So why this CARE Summit? Where did this idea come from, and why is it important right now?
Well, thank you so much, and good morning to you all. Thank you very much for being here. The reason why the European Health Management Association decided to put together this proposal for the CARE Summit is because in recent times, the narrative around health has shifted, and has shifted towards something that sounds more around innovation, around financing, around economics, competitiveness. And these are all absolutely very important points, but in our view, I think that they were sort of shifting the focus from what healthcare and health and care is all about, which is people. And so the CARE Summit, and here the name, CARE Summit, is really to bring people back at the center of the discussion. And so it's to really value the ethos, the humanistic ethos behind health and care, and is to, again, bring people back to the center so that healthcare is not created for them, but is created with them. And in this, I'm also very pleased to have here with me on the panel three representatives of organizations that are official partners of the CARE Summit, the European Observatory of Health Systems and Policies, European Public Health Association, and EUREGA, local and regional health authorities. And I think that this is another important signal around the role of civil society organization in really bringing back health to the people, because it is the job of civil society organization to connect with communities, to connect with people, to keep politics and politicians accountable for their policies, to make sure that policies are not something developed in an ivory tower, but it's something that really responds to the need of communities and individuals and peoples and their families. So I'm very pleased to have you all three of you here, and the support of your organizations. And yet again, I think that's the idea behind the summit, to recenter health as the base of our society, as the base of democracy, as the base of security, also as the base of economics and financing, but at the same time to do these with the people, for the people, and not in a completely separate way from them.
Great, and that makes sense, and I really like the point that you make about getting through and engaging with politicians. I think here in Brussels, a lot of us try to do that all the time, and I think a really important factor towards that is a strong civil society. So maybe, Charlotte, could you expand a little bit for us about how we can build a stronger civil society around health, maybe how we can engage actors outside of health to make civil society and its message a little bit more appealing and well heard by our politicians or policymakers?
Thank you very much. Hi, everyone. Yes, so civil society, you said quite a lot of things already. If we want to build a European Health Union, we need civil society. There are a lot of things written, a lot of things are said. I mean, the latest publication about the European Democratic Shield is amazing. I mean, lots of the things we've been advocating for years are there, yet the actions are not there because we are NGOs in health, but also in environment, in big danger. And I think there are 2 points. One is the political understanding of the value of CSO and some political ideology, because sometimes we don't need data to decide. Sometimes it's ideologies that decide, and we have to be clear on that and not be too naive. But sometimes it's also us not working enough together. And the commissioners say we need to break down silo in innovation, but we need to break down silos in many ways. And that's things that's, since I've been in UFA for 2 years, what we've been doing. We've been really trying to make the point about how civil society are an infrastructure coherent that translates science into societal emergency point and how we make something out of it. How civil society, yes, you said it, make government accountable, are giving trust, are giving coherence. We're also trying to show how civil society, I mean, it's worth the money. When you work with civil society, you don't only pay for people in the office, you have hundreds, thousands of volunteers. In UFA, we have thousands and thousands of hours every year done by the top-notch academic people, and we're getting lots of us, we have that. We are also, because we have this good relationship and this good kind of co-development thinking between directors, we're also, building strong links to connect to local, regional level, to connect science to management, and to have a new narrative. And I think we have to be also clear that we are in health facing we know the climate crisis, we know the aging crisis, we know the mental health crisis, but we're also having a hybrid war on misinformation and disinformation when it comes to health. And this is not something we can tackle alone in UFA, or not any one of us, but if we begin to work together on infrastructures where we say loud and we proud and we commit to be the trusted messenger, and we use not statement only, because statements are great, but I don't think communities are getting the statement. But we use our power to face the boats, to face everything that's going on, to face the ideology, and putting back things together, amplifying, and not having so much jargon, but having strong commitment and action. Because I think what we can show more is all the actions. And yesterday you showed in Eurega how many actions for public health were done at local level. Last month we were in Helsinki with European Public Health Conference, and we saw so many examples. But how do we shape the narrative now? How do we tell the story about civil society organization together with institutes? We are actually making the life of people better. And I think this is like kind of the missing dots that we need to get there, saying that we care, saying that public health has to be at the core of the security, preparedness, resilience strategy, because if you don't have us, you'll do bad strategy. I mean, resilience without public health will not work. We have to be clear on that. We also have to show health in all policy, how it is a co-benefit, how it's an investment, but we don't recognize public health workforce. We have the health and care workforce, which is recognized more or less, depending if you're a community nurse, maybe less than a cancer doctor. But the public health workforce, the people working in cities, the people working in communities, the people who are trained, we invest a lot in these people, but they're not accredited and they're not represented. They're not in the unions. Their voice is not there. So we have to make their voice higher. We have to tell the story of the people who are actually making people in Roma community get vaccinated, the people in LGBTQA community get more trust. Have you seen the number of AIDS and HIV contamination on the youth? We are missing a point, and I think together, and that's really what I hope in being there, that we can shift the narrative in silos in between CSO and going back to community and have a shared narrative.
Thank you. And indeed, I think this is a really important aspect of how we communicate with the work that we're doing. For example, we have everyone here in this room, a lot of us are based in Brussels or we work in policy, and the people who really are receiving the health programs that we're talking about, the ambitions that we have, they might not care what we have to say in this room. They might really be more interested in, can I access the care that I need when I need it? So if we're talking about the regions, you mentioned that down to the citizen level, I'm going to bring in Michaela because I think it's a natural next thing to discuss is, obviously regional and local health authorities play a major role in translating some of these ambitious policy discussions that we have here into the actual programs that citizens see at the ground level. So can you maybe share a little bit about the region's role in ensuring citizens have access to the EU health program, at least through their kind of intermediary place?
Yes, no, absolutely, and first of all, so thanks for the invitation, of course, and thanks for the partnership with this event, with everyone here, actually, because it's indeed, when we talk about implementation, we talk about making policies work for people. Indeed, as Charlotte already hinted to, you need to go as closer to population as you can, and then you do it at the regional and local level. Besides that, just to introduce a little bit, in about 2/3 of European countries, actually, healthcare is managed in a way or the other with different level of governance and competencies and budget management at the regional and local level. So it's not just about a way to say, oh, you need to be close to people, but there's actually concrete competencies and concrete implementation actions that are happening every day. And going back to transforming, let's say, higher level policy to concrete impact for everyone that actually lives on the ground, I think I would like to touch on three main points. The first one is that, of course, it's needed to have larger scale strategies, needed to have something that encompasses the entire Europe, because that's what you need to do and that's what we can do in terms of what the EU have competencies on. But at the same time, it is fundamental that these strategies have at some point a recognition on who needs to implement them. And that sometimes is something that we've seen a little bit as, I wouldn't say a shortcoming, but kind of the next step that needs to be done. And why? Because when you look at what happens and what needs to be transferred, let's say from Brussels to a city in Italy, a rural area in Spain, things are radically different. So even when you look at, the cardiovascular plan or the current cancer plan, if you think about implementation in a city or urban area, you need to do things radically different from what you have to implement in a rural area. Yesterday we had the conference indeed about mental health actions in different regions, and it was striking how everybody was kind of looking at the same differences, at the same difficulties, also based on, for instance, the comprehensive approach that the European Union has set over the years. But it was striking how everyone was kind of looking at it from a radically different point of view. We had in a panel, for instance, Castilla y León. That's indeed the region from Spain that is heavily ruralized. It's one of the biggest regions, if not the biggest, for geographic extension in Europe. But the population is really small. And on the other side, we had Wales and Flanders, which are smaller in terms of size, but they are heavily more demographic dense. So I think what needs to be done, and that's the second point, is really to cater in terms of also funding and programs for things to happen in a different way when they need to happen. And finally, the third element is that to do that, you need to know what happens on the ground, and that means data. So there's also has to be a facilitation of understanding how data has to influence evidence-based policy and evidence-based implementation. It's not just about the policy side as well.
Yeah, and it makes perfect sense because for me, that's one major point of the conversation, right? We need to be able to tell citizens, your average citizen, what it is that we're working on, and have them understand what benefits they get from it. But I think there's an alternative side to that. We need to also be able to speak upwards. So as health professionals, as health managers, we need the capacity to speak several different languages, let's say. So we mentioned innovation, competitiveness a bit earlier. So Evad, I'll come to you because we also, I think, need to be able to speak the language of finance, the language of people who don't necessarily see health as in itself the end goal they have other things in mind, other priorities. So how can we maybe make a better case for health as a better investment, a better financial security concept for our future to those people who, let's call them the bankers in the room, who might really only want to hear that type of argument?
Yeah, no, this is, of course, and also thank you for this partnership. It's wonderful that we're here together and talking about this really important issue, which is very close to the observatory's messaging in the last years. We have a whole program that is about health and the economy, where we are saying it's not about, spending on health is an investment, not a drag on your economy or a cost. And there is enough evidence to show, indeed, that there are, of course, multiple benefits on spending on health. The first one is, of course, that the narrative that we've pushed a lot is that health is a strong economic, very stable sector, recession-proof. Also anchored in the geographic space that you work in. You cannot really offshore these jobs. Stable during recession. Healthy people are productive people, that stimulates growth. So there are lots of arguments that we can bring in already to show how it's not a drag on your economy and it's a good investment to make. And lately we've been working on, also together with UFA, on the co-benefits of health, also really looking at the evidence. We have been very focused on health and all policies together. What other sectors also can do in terms of policies that then benefit health. But now we are looking the other way. So what we now call health for all policies, where we look, okay, what are the co-benefits of good health on other sectors? Some will not surprise you, education and labor, market outcomes, there is strong evidence. More and more evidence also on macroeconomic growth. We see that evidence becoming stronger. Well, we talked also a little bit about greening interventions, which can really be a strong force with positive impact on carbon footprint, or healthy lifestyle that promote eating less meat is another one. But the one that really struck me was actually the one that you were talking about, that people who are healthy do participate more in the public debate, in public institutions, and leads to a much stronger civil society, public institutions, which leads to more stability, which leads to peace. And actually, if you look at the definition of competitiveness that the World Economic Forum has, it has all the elements. It has health in there as a pillar. It has skills, macroeconomic growth, stability. It's all in there already. So I think the case can be made. We just need to put it in the right words, in the right document, and then present it to the right people.
Charlotte, go ahead.
Yes, thank you. And one common thing we've been talking about is funding. So one of the things is fighting against the loose. So if you're a member state, please press on the Commission to vote back the grants for NGOs. But if we say that health is a co-benefit of all sectors, how can all sectors give money to health and contribute to health? And there are simple mechanisms. There's something we have 1% culture in French, which is 1% for culture. I've been fighting, I don't know, for 15 years now, to try to have something, a mechanism systematic for health in all policies, that if you're doing a urban planning thing, if you're doing a finance policy, you analyze the benefits for health, and you take some money of your project, which are huger budget than health, and some money to pay for health and health promotion, health prevention expert that will tell you, okay, but this will have impact on climate and that will have impact on health, therefore in whole of your society. So you have someone from the beginning, some health expert telling you that your policy is going to be good. And it's not the health money that is really sure that is paying for that, or the healthcare money, it's the policy, it's the money there. And I think we could find new innovative systems and mechanisms that are absolutely win-win for all of us.
Yeah, and agreed, because I think some of the lowest hanging fruit is that the case is really there. We have the economic case, we have the case from a humanitarian perspective that investing in health is good for you, it's good for everyone in the room, really. So why aren't we able to make that case a little bit better? And I think to me that comes to leadership, it comes to management within the healthcare systems and within our management of health is a bit of a gap. So can you maybe, Federica, take us through some of the gaps you see in leadership and health management within Europe right now and how we can maybe help to close those to make a better case for ourselves?
Yeah, I think some of the gaps that we are observing when it comes to the work that we do at EMA is certainly that we're still working in silos. And so this is another reason behind the CARE Summit. We really wanted to bring people from different areas, not necessarily strictly health, to break those silos and to be able to really implement in practice the concept of health in all policies and health for all policies, which is not just looking at health per se, but really looking at the way other sector influence health and the way health influences other sector. So that's certainly one thing. Another thing that we are seeing in the work that we do at EMA is the fact that there is no it's not that there is no recognition, but definitely there is a little bit of struggle in recognizing middle managers. And sometimes some of the discussions that we have is how people that are actually health managers don't recognize themselves as health managers. And so that's another interesting area. But the truth is that each and every one of us in this room are health managers in different ways and at different levels. And I think, of course, another part is definitely system thinking, some visionary leadership, and being able to burst our own bubble and being able to, do a step forward and reaching out to different people. So, of course, I think that this connects with some of the things that my colleagues have said. It's about, of course, developing skills for managers. Definitely things that have to do with change management. Of course, bursting the bubble, reaching out, just speaking with people that are not our daily audience definitely requires some adaptation, and therefore change management skills are essential. Equally, Michele said it very well, we also need data, and therefore we need to have people that are digitally skilled in understanding data, in interpreting data, and in making sure that the interpretation of data then becomes a policy and it is implemented in practice. So, of course, we need the infrastructure to get data, but then also the capabilities and the skills to interpret it and use it appropriately, because at that point it's not just about reading the data and interpreting it, but it's also about implementing it. And then again, system thinking. I think that's another very important part, and important skills for health managers and health management in general.
And I think actually, speaking of Michele and your point about data, I think it's something good to touch on is we have, I think, maybe most of you will see it in the work, the higher you go up in the complexity of your conversations and in the influence and policy that your position has, I think it's more typical that we end up in these silos because people outside of our silos maybe don't necessarily understand that complexity of conversation. But down at the local level, I think people are much more used to working with a wider variety of stakeholders. So you'll have a GP in a local practice who sees someone working in every different sector, I think, throughout the day. So maybe there's something we can learn up at the higher levels of policymaking from the regional and local actors. I wonder if you have some good examples for us of things we could take into our own practice at the, here in Brussels, for example.
Yeah, I think, well, first of all, maybe reconnecting a little bit to what we were saying before in terms of having to fight and making our case. Well, I think we've been trying quite a lot. The fact is that often it seems that we're going back to the drawing board and we need to do it again from scratch. And I mean, goes without saying, of course, we're talking from the European perspective, but that indeed that has an impact with the people that we work with on the ground. So just to close on that, I think it would be really nice if we didn't have to fight for healthcare to be important. You know, I think it's self-evident, but I guess if we need to do it, we'll keep doing that. And maybe to do that, we need to indeed look at where is actually happening in a long-term perspective. I mean, one good example that we see as something that it is recognized as a long-term, multi-sector, interdisciplinary perspective. It often comes from Wales, for instance. I mean, not a new country right now, but they have been looking at how to bridge, democratic participation with experts, with something that is called Future Generations Wales. So that's actually a long-term policy, a long-term approach actually that encompasses several areas of work. It's healthcare, of course, but it touches on environment, and then it's declined to the different implementation areas. And why it is interesting? It is interesting because it connects a long-term approach in terms of involving citizens, involving experts in really having their say in what healthcare policies, for what we look at, should do, connected to long-term funding as well, because that's important to have the certainty that you're not working on like a one-year-off thing, but you're really working on a multiple year. And the funding is connected with the regular kind of monitoring and feedback loop that can change things where they're going in the wrong way. So it is interesting because basically they have this overarching approach that touches several areas, but then they decline it into different specific areas. Yesterday, again, at our conference, we talked about it from the mental health perspective, where they take this approach, they put like a long-term 10-year strategy plan with a 2-year implementation plan. So it's like policy, actions with a financial envelope attached to it that is going to be there. And then you look at it on a regular basis on what you should change, where you should maybe redirect money and so on. I mean, it is just one example because that's happening in many other ways. In the Basque Country, there have been for years value-based healthcare approach, for instance, that then they applied, for instance, in a recent cancer plan. So I think it's just very important to have something in its long-term that the professionals can attach their perspective to it, they can have a say into it, they can co-create. But then again, that they see evolving and changing based on what they actually provide as inputs, because that's what is needed in healthcare as well.
And from a higher level too, I'll come back to you, Evald, because I think this is something maybe the observatory would have a good role in, is finding these smaller initiatives across Europe and finding a way to pull out some of that information. And how do we establish what the return on investment is for some of these programs and communicate that properly to someone else who might be interested in doing the same thing?
Yes, no, of course. So we've been providing through our website lots of examples of case studies, of models that work and that are interesting and can be inspiring. And we talk a lot about the processes to make them happen. We now also have a whole special issue coming out, it is already online, I believe, about integrated care implementation. The point I wanted to perhaps also add to what Michele said, to which I agree completely, is that we also need to acknowledge, I think, towards other sectors, that we understand that we are not the only one asking for money. And I think that to show a realism and also acknowledgement of that could help. I'm saying just mentioning 2 sectors. Education will also have a very legitimate claim on, having more investments. And now, of course, the big one, defense. So therefore, I think it needs to be coupled in any way when we ask for investments, long-term investments, really important, where we also see that there is a chance, there is an opportunity to show that there is a return of investment, that we also look at those systems or those services provided that are of low value, so low value care. And there are frameworks for that where you could perhaps look and say, okay, those we are going to disinvest, and we're going to invest rather in those where we expect a better return of our investments. And I think that is probably will help us, instead of then coming across as, oh, there you have them again, complaining and nagging for money. We don't want to be that person. Yes, I think we need to have to build in that there is a longer-term perspective, and it's not only financial. It's perhaps much more about flattening the cost curve, but also lowering the disease burden should probably be part of the narrative here. That you lower the disease burden, so that you can also counter the challenges we currently have in shortages in workforce. For that, of course, we need innovations, new models of care, etc. I think that those are some of the arguments you need to bring in. And then there are, of course, structural issues in many countries. Who are the ones paying for care? Is it an insurance company who is not that interested in these longer-term investments? And is it in the competitive systems where people will run away to a different insurer, and then the investment you make in their health is gone? You need to think of solutions. The problem is just very complex.
Yeah, indeed it is. And I think it's made even more complex because when we have these good cases to make, sometimes we face an extra challenge in terms of disinformation and misinformation. And I think especially in the healthcare settings, we maybe are a bit of at more of a disadvantage than that. We had the pandemic thrust the healthcare systems into the spotlight, and it was not necessarily in a positive sense all of the time. So where education and defense, you don't necessarily have these claims that, using this type of ammunition causes autism, but in health we have that kind of discussion. So realistically, I'll come to you, Charlotte, maybe about how we might, as a civil society, combat some of this. I mean, Michiel, you mentioned it. Inclusion basically fosters democracy. So I think also putting a good message, a believable message, and fostering trust will also foster democracy. So maybe you could speak to that.
Yeah, I mean, first, I hear your point, Ewout, but when it's health and CSO, you feel like we're nagging for money. But when you're a startup, you're raising funds. I mean, we have to change our narrative. We're not begging for money. We're healthcare 2.0. We're public health. I don't know. Let's find some sexy words. There's something. I mean, no, we're not begging for money. It's all benefits every time, and we see that in mayors, we see that in city. Every time you invest in public health, people are more happy. So, I mean, happiness is always a little bit complicated ideologically, but let's just not say we're claiming for what's right. And we're also taking government accountable where they say health union and then you cut the funds. It's not okay. You cannot do that. And when it's Boston Consulting Group at KPMG, then they're not begging money, it's private sector. So there's first a very bad narrative on that we need to take our share, but I mean, we're doing that, but we really have to do that. And then, of course, it's not communication problem. I said it before, it's hybrid war. We have problems. Some problems are, yes, of course, if you're an influencer and you go and there's a very good academic on Instagram saying if you can find any influencer who goes in a supermarket and go, oh, you see, grapes is really bad for your inflammation. Don't eat grapes. And then they have 2 million views. And the influencer doesn't have, the public health academic doesn't have 2 million views. So why does it have 2 million views? Because they're organized, because they are very huge economic benefits. When Eurocare is the first of these NGOs that have been closing door, if this is a lobby against alcohol, I mean, let's see how many, if you go to the transparency register, how many lobby against alcohol are having meetings with parliamentarians and how many alcohol lobby have meetings. I mean, there's something about, it's not begging for money, is having power, and we miss power, and we are facing huge power. There's a great article in the British Medical Journal about how war is shaped by the commercial determinant of health. War is an economic benefit for people selling weapons. I mean, we have not to be naive, but we also have to say that yes, the whole narrative shapes behavior faster than science, but trust is relational. So trust comes when you have places, institutions, associations that show up constantly, and we've been failing that, and Europe has been working on that in showing up more to communities that share power, that you just consult people about the color of the wall, you consult people about really the thing that matter to them. And that acknowledge uncertainty. How do we acknowledge uncertainty? How do we tell the story of science? How do we say this comes from there? So we're working on a project, we'll should announce it by January. That would be a hub where we can do campaigns together. And when they have a campaign, a thread, and we tackle it like vaccine causes autism, we show and we use things that are done. I don't know, how many of you know Jitsu Vax? Yeah, it's an amazing EU project financed by millions of EU money that gives you lots of narrative to address the false claims about vaccination, but also depending on your population. And we don't use it. So how do we use what exists and how do we use it together? How do we put a hub? How do we cooperate more? How do we use the money more efficiently? And we don't let the project be back into the DG Regio or DG Santé background when people don't find it. How do we amplify more what the ops do? And the more we work together, the more efficient, because we need to build this narrative, and it's about hub and power. We need to have power and money.
And I think, can I maybe add something on the last point on using what's happening already? I think it's about how we need to kind of maybe look at how we define innovation as well in healthcare. There are different types of innovation. We know about it, of course. There's different types of transformation as well. But sometimes maybe it would be good to kind of stop for a second, look back at what we have already, and maybe continuing that where it's working and try to put it where it could be working, or maybe where it wasn't working, maybe try to look at that and see what we could do in a different way. That for me would be really, really good innovation. It's not just about creating things from scratch once again. That also in a situation where we growingly have less and less money and we need to kind of eventually fight with other sector for it, or fight or make our case or whatever you want to call it. There's a lot that is happening already, so we should really try to look at that as, this is true innovation. I don't need something new every time to demonstrate that I'm doing good for society.
Yeah, agree. I mean, we have 27 countries in the EU. The EU alone, not to mention we could look all around the world for some of the good examples of things that are being done in places with less resources. And some of the most rewarding work I think I've seen done is when people come together across borders, they share the work that they're doing, even if it's just within health. I think those moments end up being really powerful. So you're right, if we can amplify that as innovation, we have something happening all the way in Estonia that we could bring to Belgium, for example. This is innovation in itself, I think, is being able to translate some of those programs and policies that maybe just work and they haven't been shared properly. So I think that's a good point maybe to open it up to the audience. So if anyone has any questions for any of the panelists, I will make my way to you. So maybe if you can just introduce yourself quickly, and we'll give you 30 seconds or so to say what you like.
Thank you. Milka Sokolovic, Director General of IFA, which is not UFA. So I've been listening with very big attention. First of all, thank you for being the veterans in the fight that needs to be fought. I think I could speak about 2 hours and reacting to your things, but I was noting the keywords, some of the keywords in this discussion that include investment, competitiveness, health in all policy, and data, right, and evidence. And still we have more than sufficient evidence of how important and how big a return on investment would be if we invest in prevention. And we are failing to convince our policymakers, even in those basic points that need to be, or actions that need to be taken. And Charlotte has mentioned the example of Eurocare, the example of the alcohol lobby, and there are more. We have the tobacco directive, we have like all sorts of things related to, at the end of the day, the conflict between commercial interest and public interest. So how do we bring innovation into that conflict? Or should innovation be called revolution? So over to you. Come up with something innovative.
Thank you. And I'll let our panel decide who wants to take on that one.
I spoke about revolution leads to me. I think, I mean, public health comes from activism. We come from that. I mean, we forgot how to fight. There's a very good article about that. I think we should all go and see the 30 or the 80 director from the Civil Society Alliance for Health and sit in front of the President van der Leyen office. I mean, Matthias, you were telling me that the latest discourse was really making very well the link with health prevention and resilience and democracy. So she get the point. I mean, if we don't do that and just make statement again and consultation, we do the long term, but I think we need short term. So I think protest. I think we should block Brussels with ambulances like they do with tractors. That's a personal point of view, not UFA point of view.
Thank you, Charlotte. I think what I would like to add is, of course, we talked about fighting, and then we said no fighting, and then we talked about revolution, and we said no revolution, and then Charlotte wants to block Brussels. We are very peaceful in this summit, just to be clear. But I think to step a little bit away from the, let's say, fighting part, I think that there is a lot that we can do as civil society organization, but also all these people in the room in really being united in these endeavor of advocating for health. I've often referred, maybe in a little bit interesting way, to civil society as disorganized hippies. At least that's the image that sometimes comes across. Whereas the consultancy, the private sector, they're all those in important suits, and they are able to make the case. But the reality is that civil society has such an important power in terms of people that we can mobilize, the way we are connected to society, to real people, the way we observe the change and the impact of policies on the daily lives of individuals, that we should definitely come together and leverage these power. I think that for me is the real, very peaceful revolution.
And we have another question over here.
Yeah, Iñaki Gutiérrez Ibarluce. I'm currently the Director of Health Innovation, Research and Evaluation of the Basque Government, the Ministry for Health, and also the Vice Chair of EUREGA. I have two questions to the panel. One is related to, do you think that we are collecting the needed data? Because most of the healthcare systems, we are collecting data around processes and structure, but not about value. So do we have sufficient data in this sense in terms of making decisions? And the second thing is the way that we are valuing interventions, it is precluding. What do you think about, for example, the current paradigm of cost effectiveness? It is useful in terms of making that possible. So it is precluding for prevention and promotion.
Thank you, Iñaki. Maybe, Evad, that you could have a go at that one?
Yeah, the two questions are first the data one. Yes, we need more data. I think that in any public appearance that I have, I always talk about data, that we need to. The right data, and I think there's a role for the European Commission, and for me it's a kind of a low-hanging fruit to standardize and have better data. There's a lot of data around. You're of course right. So in that sense, no, we don't need more data. We need better data. But nevertheless, I think that is a no-brainer, and that we can work towards. And there are many examples to give about cost effectiveness. I think that prevention, it's always been difficult. There's no direct, there's no evidence for direct cost savings. So it's much more about what I said before, that we need to show how early life interventions or other forms of prevention then will lead to lower demand in the future, lower disease burden that makes a more manageable health system, will flatten the cost curve. I think that is the direction we need to go, and I think people will be susceptible for that. And maybe to come back to a previous point about begging or nagging, I don't think, of course, that we are nagging. I think we have great arguments, but it's often how we are seen, and then we need to acknowledge that a little bit. So that would be my short answer. I don't know if you want to add.
Yeah, it's also about efficiency. I mean, when you do something like you were telling us yesterday about suicide prevention capacity building you're making, you invested at, I guess, at level of Basque Country, and you did something, and you invested money and time, and this has benefits for everyone because you're also saving money, but it's not the people who invested the money who are saving the money because national administration. But if we would, you know, as us, use what you've done, this capacity building, and translate it and use it in other places, then other regions will not have to invest in the same thing, they can adapt, but then we leverage on that. I think it's not always about just proving the case, because we've been proving the case, it's about making things different. What you said, system thinking, how can we leverage on what we have?
Yeah, maybe one thing that I wanted to add is that, yes, we've often been looking at the traditional outcomes of the triple aim, for example. But like I said, why not look at the future disease burden? But the other one is greening. If we can show that by and greening measures in health are actually very efficient measures for the system, like cutting out waste, I think is a good thing. And it can also contribute to wider goals and meeting certain national goals in terms of climate and climate change. I think that is another narrative that deserves exploring more. I mean, I think we're starting with it, but I think this is one that is powerful.
Great. We still have time for a couple more questions. I think I saw another hand somewhere. Sure.
Hello, my name is Vildana Mujkic. I'm so happy to be here today because I'm patient advocate and healthcare advocate. So I believe what we heard today at the same beginning, that we need to be focused on people, so not to talk about us without us. So I believe this is a great example here. But when we talk about framing some, let's say, new approaches, I believe we should just reframe. So we heard here today, like, we don't have enough funds. I believe we do so. So this is what we witness in everyday life in respiratory and immunology diseases. This is where I come from GAP, so we are focused in these diseases. So what I want to say, so we have a lot of money comes from a tobacco industry, so they want to return to us. So I also heard this social entrepreneurship, so they want to feel like they're doing something for the community, and not even penny, for instance, in Eastern Europe, Southeastern Europe do not come in prevention or treating the patients with respiratory diseases. So I think it can be reframed, and we can get, there is a money if we can do evidence-based advocacy, if we can show how comorbidities, the diseases that comes after not treating or not being, not push more for prevention, that there is money, and we can prove that we can do some savings. But if there's a health economics analysis in focus, so if we have someone who can help us to advocate as evidence-based, to do evidence-based advocacy, I believe we can make some changes. And about data, I would agree. There is a lot of data that we don't know what to do with. We work in silos, there's no heart or brain of that data. So you have to make it in real-time context, not just have data. So a lot of things to do and to discuss about it. So we have a lot of things, but to integrate those things into real context exactly is something that we are missing. So more than...
Right, thank you for that. And I think maybe if I can paraphrase as a question for the panel, how do we give these advocacy tools that we've been talking about building as health managers to everyone? How do we give them to patients specifically, to the people who need to advocate for their own health?
I don't know if technically I can respond directly to the paraphrase, but I mean, I think we've been doing evidence-based advocacy, all of us, to be honest. And I think it shows that, even practical example, I was reading the other day, the midterm EU for Health evaluation on looking at how it's being used, over the past few years. And it does show that, for instance, funding, that it is there, I'm okay. Going to organization that's been getting operational grant has been working, has been impactful because it allows to do evidence-based advocacy. On the point of like asking necessary for more money, I do agree. I think we need to be clever in understanding how we ask for funding for the right things, I would say. Because it is true that, there has been billions of euro indeed invested in projects, and across years and in activities, and there will be. But like what we're making out of it, let's say how we can use efficiently, that I think that's the question. And I lost like on the second part of it, but
no, I think you're doing good.
Second thing, but maybe we can chat it later. Yes, on data. Just quickly on data, I do agree also with what Iñaki was saying before. I think now with the health data space, we're going to talk about it later, so no spoilers. But it's an excellent opportunity not only to push for more data in general, but push for the right one that will actually make things work in a better way. I think we need to say it collectively, that we need to maybe stop and look at really what we need and listen to the ones that have been doing it for years. Because again, it's not since today that we're starting to collect data, as it's not since today that we are trying to do evidence-based advocacy. I don't know if I answered, but eventually.
Yeah, no, you mentioned a couple of interesting things. Also, what we would call social participation, which I think is a really attractive area to explore, and where we will definitely focus more on how you involve the people also in care. People with lived experience, and there's such powerful examples that we need to explore. Now, I wanted to come back also on the data point. That one of the things that are, for example, missing, you can improve all kinds of data that is currently being collected, and I can give you examples, but I will not bore you with that, but is data on vulnerability. I really think that, to be able to reach out to those people who need it the most, and it's exactly what we need to do, because those are the people who felt left behind by the system, who are then really also prone to vote populist, and that leads to a vicious cycle. In order to really reach them, you need to have targeted mechanisms to reach them, and for that you need that specific data that we're currently not everywhere collecting, or not in a very disaggregated form, also for all kinds of political reasons.
Yeah, and so that's a great place, I think, for us to start to wrap things up. But I think we've talked to, and the conversation's taken us far from this room. We've been all over Europe, I think, in this short hour. But I will bring us back to the room and give each of you just one last thing. I'm going to ask you a quick question. Sorry to put you on the spot. But if you were going to speak to the people in the room today and say one thing, one piece of advice, or one thing you'd encourage them to consider as they go through the more detailed sessions for the rest of the day, what would that be? What should they have in their minds as they go through the rest of the summit today?
Well, if I start, then I think it's about this message of how pick up those things that you can then use for yourself in your work to make the right arguments to the right people, and listen carefully what you hear. There's also some of the new arguments that you perhaps were not aware of, although with such an audience, I doubt that there are, but maybe there are. So I think that is how I would be here, thinking of how can I use this to improve how I do my work.
I would say build alliances and go political. I mean, write to your member of parliament, to your mayor, to your Ministry of Health, to your commissioner. Build alliance and go political. It works. We talked about it yesterday. It works. Writing and writing and writing to your politician, saying the evidence, but a lot of time, if we would all like, health is not a cost, it's an investment, and we go and go and go, and then it comes common language. Because sometimes we just change the narrative all the time. So let's build alliance together, connect, don't speak to the people you know, speak to the people you don't know.
And maybe on that, try to understand if somebody else has been trying to tackle the same issues that you have, or maybe they tried and they failed. And also maybe don't be afraid of mentioning what went wrong. Sometimes we a little bit obsessed, so it's like just showing that we reached that KPI, that we delivered that document. Sometimes we don't make it, and that's also kind of innovation for somebody else.
very hard to go last because they have said almost everything. So I think that what I would advise all of you is to break silos. I think that's also the idea behind these care summits is about discussing different things. Of course, there will be a lot of overlap, but let's try to think beyond the typical borders that we are used to have in our minds and heads and work. And so let's break silos. Let's burst out of our bubbles.
Great, and I think that's a perfect way to end because we have half an hour now to do just that. We can go out, get some coffee, break some of those silos. But first, I would like you all to join me in giving our speakers a warm round of applause. I think it was a great, refreshing session this morning.